Good afternoon and welcome to United TV. My name is Kemal Erkan. It's our Bariatric Friday event every Friday, 3 p.m. Today, Dr. Gail Wynn is going to join me. This is your second time, Dr. Wynn, here in the new studio, not in the live events. But it's always have a different setting, right? It's a nicer setting here, right?
Yes.
The bariatric surgery. I do have a couple other sessions related to this topic with Dr. Erkan in the past. But since then, we have our research, internal statistics, I should say, not research just yet, because there's still some work that we need to do. We want to share those outcome of those patients. But before we go into all that discussion, we have some new people in the audience, and they may not know exactly what we are doing. What morbid obesity is and how bariatric surgery is helping, why it's one of the best and most powerful tool to fight morbid obesity. If you can give us that background, and then I'll start with my questions. I say qualify is just like the lack of term, but for patients who are considering surgery, what are the criteria for the surgery itself?
So the criteria for surgery is having a body mass index greater than 40 or a body mass index greater than, depending on what type of insurance you have. Most insurances will cover surgery if your body mass index is greater than 35 with medical problems like diabetes, high blood pressure, sleep apnea. A body mass index greater than 40 is equivalent to like being about 100 pounds overweight. Body mass index of 35 is being about 70, 80 pounds overweight with the medical problems. The American Society of Bariatric Surgery has lowered that criteria, and some insurances have accepted that criteria to a BMI greater than 32 with medical problems like the diabetes, high blood pressure, sleep apnea, heart disease.
So in these sessions, we discussed so many times. Now it's on the regular cycle. Different topics, different ways to handle issues, patients who are going through the surgery, they're not there yet, and there's also patients who are post-surgery. And 2 weeks ago, one of our patients from 2020, she was here with us, and she shared her own experience and what she went through, and seeing the outcome was amazing, and she was also brave enough to come up here in front of the cameras and then share her own story. And that kind of makes it extremely powerful to see the actual outcome. Now, in the last several years, we have seen weight loss drugs also utilized in morbid obesity and treating morbid obesity. And there are so many new ones coming up. And it's almost one of those things where people didn't do anything for morbid obesity until 2010, right? And then all of a sudden now we have, after the surgery options, we have also now medications. Some of them are good, some of them are more efficient than the others, but it's not for everyone. But before we get into that, if you can kind of give us the background on these drugs, what has changed and why do we have so many different options now?
Sure. So early on, really the only medication that was out there to help people lose weight was something called phentermine, which was a stimulant. It's still being used today. It's actually one of the cheapest medical weight loss medications, and it basically works by suppressing people's appetite by working on neurotransmitters in the brain. And then came these diabetic medications, and they were used to treat diabetes, but what they found is people lost their appetite. And they also started losing weight. And so it became kind of like a side effect. And so people started using it. First, it was like Contrave, which was one of the early ones. And then they came up with these injectables, which everyone hears about, the Wegovy, the Saxenda, the tirzepatide, which is Zepbound, or Mounjaro. So these medications have actually been shown to help people lose weight. The amount of weight that you lose say for Wegovy or Saxenda, is about 10% to 12% of your overall weight. And then when the Mounjaro and Zepbound came out, it showed that it was even better, maybe like 14, 15% of your total weight loss. When you compare that to surgery, surgery still helps you lose anywhere from 20 to 40% of your total weight. So surgery still is good, but these medications are helping people almost get to where surgery is, which is pretty incredible. When before, the old medications couldn't even get there. They'd help you lose 10 to 20 pounds maybe, and if you came off of it, you gained the weight back. And so that's what's nice about these new medications. The only problem with these new medications is you have to stay on it, and then they're also expensive.
Mm-hmm.
And then because everyone wants to be on it, it's also not as available.
So these are GLP-1s, right? We are like the clinical terms, GLP-1s, and from the United Medical ACO standpoint, we, as you know, I have 2 case conferences every day, 2 sets of case conferences. We start with United Medical ACO, and there are about 10, 11 nurses in 2 different teams. They present different clinical cases. And then we have our bariatric case conference, and then we just discuss every patient who is in the surgery pool, and then we see what they're missing and how we can help them. Now, because I see how expensive these medications are, and also not seeing actual real-life results from patients, then I have a small group of, small team in my office. We went through these cases which were presented, and those patients who's been on these weight loss drugs, and see how they are being managed and what the outcome was in the first 6 months and also for first 12 months. So we finished we finished the 6 months, working on the 12 months. Data is validated for the outliers. So the surprising part of it was in about 147 patients, the total weight loss we saw in 2 months was only 2.5%. So, and these patients' BMI is 39 and over. They're actually 40 and over. So, and looking at, in some cases, we didn't actually see the follow-up for 6 months. They're not being measured. They don't have nutritionists. And yet this is 2.5% total. That was kind of really low, right? So some of these drugs, I mean, the range of the cost of these drugs is $1,500 to $2,500 a month. And one of the reasons that I was actually also looking into this to see some patients or some people who have morbid obesity, they were making the perhaps the mistake of, hey, this is the right thing for me, so then this is why they call it weight loss drug, but then your BMI is 57. So I guess part of our discussion today is going to be around this issue of when this is right, especially when we don't see really good results just yet, because those statistics that pharmaceutical companies are sharing, they're in the control groups, right? So those are, they're control groups. So
Yeah.
this is random with patients who are on these. Go ahead.
I think the other thing that the pharmaceutical companies don't tell you is that the range of that weight loss that they measured is not over 6 months. It's over a year to 72 months. 72 weeks. So it's like a year and a half. So if you're losing 10% of your weight, say you're 200 pounds and you lose 20 pounds, that's 20 pounds over about a year or a little over a year. Or depending on which medication, it's like a year and a half. So it's not as dramatic as you think it is.
Mm-hmm.
And so I think people kind of rushed into this thinking, oh, I just needed to lose weight. I just need my appetite suppressed, without really thinking like, oh, I actually need to go on a diet. I need to learn how to eat right. I actually need to exercise, because there's a lot of studies out there right now that are showing that a lot of the weight loss that you lose with these medications is actually muscle wasting, 20% muscle wasting. So if you're not lifting weights, you're basically losing your muscle, and not just your fat. So
And why is that important?
it's important because, one, muscle is metabolically active. It's actually burns fat while you're sitting. Number two, it's what gives you your longevity, your strength, your everyday moves. And so if you're losing your muscle, basically you're losing your energy, you're losing your mass, you're losing your ability to function. So
I some of these questions I asked because I'm the messenger. So I kind of knew the answer, but I just want to make sure that patients and others can directly hear from you. You know, what makes our event special is it's not me, who's a non-clinician, talking about clinical issues on my own. I'm just a person who's orchestrating this all together with the people who are best in their field. You know, I was joking with Ethan earlier, but I wasn't really joking. So when you got here, so you are a big deal. So you have to be a big deal. So you are one of the best bariatric surgeons in the world. So then I can ask some these questions so that people can directly hear from you.
Right. So, I mean, I am a bariatric surgeon. I've been doing this for like 25 years, but also I got board certified in obesity medicine. So I could really understand what it is that we're doing, and maybe really incorporate everything into the treatment of our patients to give them the best outcome overall.
So I guess just helping those people out there to make better decisions. In some cases, they reach out to us and they're seen in our offices, either in our surgical office or in the other settings, in the primary care setting. But for those who may not take that action just yet, one important thing is they have to make that decision and take an action, regardless of which way they are going to go. Doesn't matter, right? So because if they have the awareness of, hey, I need to fix this problem. So that needs to be there. So then there are solutions. So solutions again with the drugs and the surgery. So when is it the right time for just keeping people on the weight loss medication versus, hey, it's time for the surgery? Or is it something that we don't even have to need to process it in that fashion?
So it's interesting. So when I evaluate a person that wants to lose weight, I look at them as, okay, how much weight do you have to lose? And is it achievable by medications alone? And so I talk to them about the pluses and minuses of surgery, of medications, and I kind of let them decide, because some people are not ready for surgery. And they're like, can I just try the medication first? And I'm willing to do that, knowing that maybe they need to lose 100 pounds and they're not going to get there. And I'll tell them their realistic expectation with medication alone. And probably, a third to maybe a half will come back and say, okay, either I can't get the medication, it's not available, or I'm ready to consider surgery, it's not working for me, or, sometimes it's just frustration because they feel like the medication doesn't necessarily help them achieve their goal. The medications don't work for everybody. It works in different ways. There's studies that show that might be genetic related, that some medications work better for other people, but it's based on genetics, and we're not going to genetically test everyone before we start them on a medication. And so one of the things that we know doing surgery is that the surgery works for everyone, right? And so when someone comes back and says, I want surgery, or sometimes they just choose it originally, I could say, okay, these are the steps. You have to see a dietitian, you have to see a psychologist. We're going to get you through this, but then afterwards, I'm going to be there for you for life to counsel you as you're losing the weight. And if you start faltering, if you start gaining weight, if you can't control your hunger, we can add these medications also afterwards to help you. So I think medication is a good adjunct. So you talked about the person whose BMI is 57. I would probably start them on medication right away as they're going through the process for surgery, and then say, okay, let's do surgery. And then, maybe 6 months to 9 months into it, put them back on the medication to get them to try to lose as much weight as they can using both. If they have maybe 100 pounds overweight, BMI 100, I feel pretty confident that surgery will help them. I think medication will help them lose probably, if you're 100 pounds overweight, maybe 30, 40 pounds. And if you're okay with that and you feel healthy at that weight, great. But if you don't, then we need to add something else.
So I think going through so many patients every day, me personally, and also discussing these with my friends and our physicians, other providers, the expectation that we have from the solutions that we may have in medicine, that kind of that puts us in trouble, in my opinion. So because, from the patient standpoint, I'll just tell you, I'm going to take this medication and I'm going to do nothing.
You're absolutely right, yeah.
Right? So I'm going to take that medication and I want to go to McDonald's every day and then eat their unhealthy, food and drink soda and drink alcohol and I don't want to work out. Like, I don't want to change anything on my fitness, right? So just trying to put this in perspective from the patient's standpoint. So this is not happening, right? So this is kind of like, we want to kind of clear the air for this. So, and this is even true for, to a degree, with the surgery. Like, yes, surgery is more powerful tool and the results are much definite in many ways, but that even needs certain collaboration with your surgical office, with your nutritionist, with your primary care, go through and then get the maximum out of it. But I think the most mistakes that I see is on these medication signs. Just like any other medications that's available today, that if it has this little magical twist, right? So, I'm going to take this and I don't have to change anything. Is that what you see with your patients, and how do we actually fix that?
So you do see it a lot with patients. At some point I had a telemed visit with a patient that is eating her potato chips while she's telling me that she is on like Manjaro and she's happy she's losing weight. And I said, you actually have to change how you eat. So I think that's a big conversation I have with the patients starting straight off. When I interview them, I talk to them about their diet, their exercise, and their expectations. I tell them about what medications will do, but they still need to diet and actually exercise. And I think whether it's surgery or medications, you need to treat them the same. They have to see a dietitian or see their surgeon regularly for counseling, or their physician. Because if they don't, then they're not changing anything. And I think that really successful people really need to look at, let's track my intake, let me start exercising, let me become more active so that I could be successful long term. But, the other thing is close follow-up. When we see these patients, we don't see them every 3 months. While I'm seeing them and starting them on medication, I see them once a month. And then I see how they're doing. Do they have side effects? Did it work? Did it not work? If it didn't work, we up the dose. If it still didn't work, then I up it again. And then I tell the patients, like, listen, if you don't lose weight with us, we're not doing this medication anymore, because you actually need to actually put some effort into it.
Well, I think part of this study was interesting to me, and I don't know, Ethan, if we are going to bring up any of the pictures, and if you can bring the one with the age bracket. Some of these patients, these are averages, so it's about 147 patients in this. Again, we cleaned this up to make sure that, like, there was one patient, it's, okay, I'm just going to tell you, so not giving any names of the practice or anything, but patient lost a lot of weight in 6 months. Well, that was not the case. So because we are looking at the outliers, so when this patient lost 30%, hey, this is great. Let's see if we can get this with other people. So patient didn't lose. It was just entered incorrectly. What was interesting to me was I didn't see that's being addressed. So if I have a patient who lost 100 pounds, in this case it was 100 pounds, in 6 months, then I'm going to actually mention that in my note. I'm going to say, hey, you did great. So then how did you do it? And all that stuff, right? No, they just put the 100 pound less from the last visit, like from the beginning, and they didn't even address. So if that was correct, then, celebrate that, right? And if it's not correct, then find out what it is. So there is this accountability issue with this, because what you are saying is extremely important, because you want to see your patient every month and see if they're actually seeing the result. And if they're not losing in 6 months, or if they're losing only 2% or 1% of their total BMI, there is no sense to keep those patients on this really expensive medications. Now, the state of Delaware, for their employers, for their employee program, they budgeted $55 million for weight loss drugs.
Wow.
That's a huge impact on their financial budget responsibilities. It's a huge number. And this is not for the entire state. This is just for their employees. And yet I see this, and I feel like from an accountable care organization standpoint, it's my responsibility is to share this with my clinicians, but also with the state officials, with the insurance companies, to see, hey, what is the right way to, monitor and administer these drugs? When we don't see results, when do we stop?
Mm-hmm.
Now, again, in this report, what we see is that one actually, Ethan, is the gender breakdown, but the one before was the age. And the age breakdown was, there are some patients, they lost maybe 10% or so, but when we look at the averages, average is about 2.5%. And then I'm like, when do I stop? From the clinician standpoint, isn't that my responsibility? Right?
Absolutely. The cutoff usually is less than 5%. If you lose less than 5%, then you really need to either be on something else or consider surgery. If you've tried and tried and tried for 6 months and you still can't lose up to 5%.
Right. And even with this data, now we can do the gender breakdown. So, and I couldn't help but thought about what you just said about the muscle loss, because in this breakdown of the female versus male patients, the average male patients is about 1.3% versus for average female patients loss is about 3.3%. Now the report is not final, where there's some patients who are on Medicare. That's why it says 1 and 2 versus female and male. But even in this not so great outcome, female patients lost almost more than twice actually. Is that because of the muscle loss? Is it related to that, or
Hard to say. Either that or maybe women are just well more motivated than men.
So true. Now, well, one of the questions I have. So you mentioned some of the drugs, like the Ozempic versus Wegovy and the Mounjaro and the Zepbound. Some of these are same formula, but
Right.
they're actually approved for X versus Y. And I'm having a little bit difficult to process this. How does the body knows, hey, this is not approved for, weight loss? If I have, let's say, patient has diabetes, and if they're at BMI 32, if they're on Ozempic because they have diabetes, we are giving that name but same formula. We still expect that patient to lose weight,
Oh, absolutely.
right?
Yeah,
Because that same formula is labeled under Wegovy, and then it now says weight loss and diabetes.
Right.
So if these were so powerful and so efficient by itself, the drugs, all those patients who don't have morbid obesity, but they have at some level of obesity, they also would be losing certain amount of weight,
Yes.
right? So because our body doesn't say, hey, the FDA didn't say this, so I'm not going to actually, I'm not going to actually use this for this reason. So that's also another issue because even a couple of people from my team, they challenged my data saying that, hey, you need to consider those patients with diabetes. I'm like, they should be losing weight regardless.
Right, right.
And then diabetes patients have a similar, we ask them to follow the similar discipline in terms of the weight loss. They need to be watching their nutrition, their fitness. So like we are not just going to rely on medication. So then expectation would be, hey, everyone should be losing weight. And that's not what we see.
Correct. I think the only difference would be that when you're using the medication for weight loss, you're titrating it to their hunger and their desire to eat and their suppression of their appetite. Versus when you're using it for diabetes, you're using it to, oh, is your diabetes controlled? If it is, then we stop at this dose. We don't escalate it.
I see. Yeah. Yeah. So, and that's another thing that I see, another perhaps issue where patients on the same dose, if they're not losing weight, do we not want to increase that dose?
Exactly,
Right?
exactly.
So this is why the monthly visits are important.
Yeah. So I had a patient today that I saw actually who has been on the same dose for like a year of Manjaro, and she says it's doing great with my diabetes. And I said, well, tell your doctor to up it a little bit because you're on the lowest dose and it could help you with your weight loss. And she's like, oh, okay, didn't think of that. And
Right.
I thought, okay, well.
So because it's new, I guess, I mean, it's still like a couple years only, and so many people are trying to do the same. And one of the issues with the celebrities, like Kim Kardashian, she goes out there and she says, "Oh, I lost this much," and then there's even like this term called Ozempic phase or Wegovy phase. So they are promoting, and it's not really. There's really no good foundation for those promotions. And our goal in these events is to increase public awareness of what's real, what's not. One, main thing for me is understanding nothing is magical. So,
Absolutely.
that would be so great. Like if I take some medicine and if I have more hair, right, that doesn't work. So the best, most efficient hair loss treatment is hair transplant. So nothing is going to bring your Rogaine is not going to bring your hair back. So same thing with the weight loss. It's just unless you have the commitment, and this is one of the takeaway from the discussion with our patient Karen Riley, and she said, "Hey, this wasn't easy. It wasn't just surgery. So I put my heart into this, and I made the commitment to change what I do that time." And I need to be able to move. I need to be able to do other things. I need to be able to go out, help my kids, and all those things with the motivation coming from those, family related tasks, the pressure that she's getting from those. And she said, I changed. It's not like I haven't changed anything prior to surgery. I changed completely, and surgery was this kind of like jump start to put me out there, and I don't have to wait too long to see my results.
Mm-hmm.
So, but it took more exercise, better diet, following a better diet, and vitamin utilization, all those things. And she lost almost 110 pounds. She was 260, and I believe last time she was 147. So, and to keep it up, just like we do. So now, are you still playing pickleball?
Yep.
You guys make way too much noise, just to let you know. So I'm going to start a bill from the state to stop the pickleball in public places.
No.
So I'm kidding. No, it's seeing so many people going out there and play, and that's not the only thing you do.
No.
So you're extremely active. God bless you. I try to walk 10,000 steps a day. And trust me, it requires effort to do that. And it's not enough by itself, so I still have to follow certain diet, intermittent fasting, and other things to stay away from certain food and drinks. So it's a combination of all those together to have this, make this more like a lifestyle, so that if someone is at the morbid obesity level, if they have the same understanding, they can utilize either it's a weight loss drugs or the surgery as a jump start. But the best jump start right now and the most powerful one is the surgery. So when do you, like from the clinical standpoint, from the clinician's side of view, when do you say no to the patient when they are definitely not the right candidate for drugs?
So one, if there's a contraindication to the medication. So for any of those GLP, GIP, GLP combinations, is if you've had a history of medullary thyroid cancer in you or your family, then all bets are off. If you're pregnant, if you have a history of pancreatitis, those would be reasons not to be on any of those medications. The other reason would be is if you can't afford it, right? Like if you can't afford it, you're not going to be on it. And Medicare is kind of one of the tougher ones to get it approved for. And so it almost automatically takes you out of the picture. And then you have to look at, okay, I started you on the medication. I see you monthly. You are still eating potato chips. I counsel you over and over like, hey, you really need to eat better. And you say, well, I'm just really struggling. And so I keep increasing the dose and you still can't do it. Basically, if you can't lose weight with escalating doses of the medication, then you really shouldn't be on it. We need to try something else.
Right. So for our kind of final takeaway from this discussion, medication, weight loss medication versus bariatric surgery, what would be our final message to those who are watching us right now?
I think the final message is this. It's important to lose weight and keep your weight down for health reasons and longevity. So you want to take a medication or a surgery if it's going to help you. But you have to go into it thinking that I actually have to change how I eat. I have to eat healthy. I have to exercise along with it. Alone, they're not perfect. But with good counseling, eating right, exercise, it's a great lifestyle change. It'll give you a new life.
All right. So, well, thank you for joining us. You were in our Dover office today, and you did some surgery center cases, or
Not today.
Not today. So that's about an hour away from here, and then it's another hour to your home. And you took your time and then stopped by and then share your insight and your knowledge with us, and we appreciate that. And that's why this show becomes more important and special for those, because we have board-certified clinicians who are advising us on the clinical issues. So don't wait and don't take too long to make the decision that's going to actually help you to live longer and healthier, and spend better, more quality time with your loved ones. And regardless of what the solution that you are looking for, there are different tools available. And our goal is to put them out there and then for you guys to make your decision. And the worst thing that you can do is come and see one of our physicians, one of our providers in our primary care settings, and see for solutions. That's the worst thing you can do to yourself. So it's the easiest one that you can do to yourself, right? So take an action, and then hopefully we can make an impact in the longevity of your life and your quality of your life. Thank you for watching us, and we'll be back next week with another episode.